morning, everyone, and welcome to our second of 2 videos on joints. Hopefully between the last video and this one, you guys have had a chance to review the actions that a lot of these synovial joints can do. It'll be really important because we're going to be talking about them a lot today. Now, one of the things I want to talk about in regard to synovial joints. Remember, there's a lot of different types of synovial joints. We have gliding or plane joints that kind of slide over each other. We have our hinge joints. I'm using my wrists, not really hinge joint. Our elbows, knee. We also have our ball and socket joints, like your shoulder, that are going to allow us to do a lot of range of motion. But there are limits to that. So that's what I want to kind of start with today. So first off, the range of motion at any synovial joint is always going to be dictated by the 2 bones that are coming together. If you remember from reviewing the actions and the joints prior to this, you will see that we talked about, for example, a saddle joint has sort of a C-shaped bone on one end, a C-shaped bone on the other, and they sit like this, and that's what gives us the typical saddle joint action we can see with a thumb. We have our pivot joints where we have sort of a rounded bone and then a curved bone. It gives us that pivot action. So the shape and structure of the bone is what's going to give us that articulation. Now, the other component to giving you good range of motion is your ligaments. Remember, the ligaments are going to be part of that fibrous capsule that are the outside of the synovial joint. We also have some that are inside. We'll talk more about those today as well. And the tenser those ligaments are, the less range of motion you have. And the looser they are, the more range of motion you have. Now, in a normal functioning joint, we are going to bounce around between taut and loose. So some ligaments will be tighter during certain activities, others will be looser during certain activities. For example, the 2 crossing ligaments inside the knee make a little cross like this, the anterior and posterior cruciate ligament, I kind of mentioned them in the last video, they alternate who is tight and who is loose. So when your knee is bent, as it is probably right now because you're sitting, your ACL is going to be loose, but your PCL will be really tight. And then as you stand up, those roles reverse, okay? You can also think about it as well as we don't always want all of our ligaments tight. We don't want to completely restrict that range of motion, and we don't want them always super loose because that can lead to problems. In the last video, I mentioned that I have some issues with a lot of my joints. So I have what's called multi-directional instability. We'll take a look at that when we look at the shoulder. And that means that my shoulders, the ligaments are quite loose. It's like that with a lot of my joints. And so they pop out quite frequently. One of the surgeries that I had was called a thermal capsulorrhaphy, and I'm not even going to try to spell it. But what it was supposed to do, is it sort of heat shrunk the ligaments in my shoulder to make it tighter. Unfortunately, it has a really high level of failure rate, and it did fail in myself. But the goal there was to, if I tighten your ligaments, I'll reduce your range of motion. Now, the other factors that affect the range of motion are the muscles that are going to be running over and crossing the joint. Now, these are very important. So, for example, in a shoulder injury, we want to strengthen the muscles that are going to be crossing the shoulder joint because they're going to help keep that shoulder joint in place. That's why when you go to physical therapy after any sort of surgery or injury, the focus is on strengthening of the muscles because the stronger the muscles are, the more assistance they'll give to keeping that joint in place and stabilized. Now, naturally, too, we do have sort of limits on how much we can move our joints due to the amount of tension that's in our muscles. So some of us are a little bit more limber than others, so you're able to move your, for example, you can do the splits. We'll talk more about that a little bit later. Or you can just stretch your legs or arms and bend your back a little bit differently because your muscles are a little bit looser. You can reduce the tension there. So one example I want to give you is of the hip. So with the hip, I want you guys to all try this. If you stand up and try to lift your leg straight up like this, keeping the leg straight, you'll notice you can probably only lift your leg maybe to 90 degrees, okay? Which means sort of straight out like this, okay? The reason most people typically can't lift it higher than that is because of our hamstrings. They're pretty tight, and so they limit the range of motion at the hip joint. But if you bend the knee, that's going to reduce the tension on your hamstrings, and you'll notice if you bend your knee, you should be able to lift your leg higher. So I want you guys to kind of try that. Lift your leg straight up with it completely extended, and then try seeing how far you can lift it when you bend your knee, and see that you'll be able to lift it a little bit higher. Contact of soft parts is going to be the next factor that's going to affect your range of motion, and that means that the soft tissues around the joint, the muscle, the fat, are going to affect how much movability you have in that joint. So for example, think of The Rock, right? He has really, really huge, giant muscles. So his ability to bend or flex his elbow, he may not be able to do what I'm doing because there's so much more muscle here, okay? Same thing with adipose tissue. If you have a lot of fat, you may not be able to, for example, in your thighs or in your butt, you may not be able to completely sit on your heels, okay? Or you, once again, may not be able to completely bend your arms. It's because, not because your joints can't do it, it's because there's just something blocking it. So more muscle, more fat can actually affect how you are able to move your joints. Hormones are also really important when it comes to the ability to affect the range of motion. In females especially, our sex hormones just in general tend to affect the laxity of our joints. So some women may notice around the time of their period, their joints get a little bit looser. Once again, we talked about this before in the last video, but during pregnancy, we have that hormone relaxin, which is going to loosen the joints, and particularly within the pelvis to help widen it for delivery. And finally, probably one of the most obvious factors that affects range of motion is disuse. The old adage, use it or lose it. So if you are laid up due to rehabilitation of a surgery, or maybe you had your arm in a cast that went over your elbow, when it finally comes off, you're going to notice that joint is much stiffer because you haven't moved it in a while. So immobilization can actually lead to a lack of range of motion. So now what we're going to do is we're going to focus on some of the more special joints that we have in the body. Once again, if you didn't have a chance to review the types of synovial joints, plane, gliding, ball and socket, hinge, things like that, go ahead and pause the video, just review what those terms mean. We will be kind of talking about what they are today as we go through these, but what we're looking at here are sort of special joints that tend to have a lot more clinical significance to them. So the first one we want to talk about is the temporomandibular joint. So that's going to be your TMJ, the one that's connecting the mandible to the skull. It is the only movable joint in your skull at all. Remember, everything else is fused together typically as a synarthrosis. It is a hinge joint in the fact that we do get that sort of hinge action like a door. So it kind of opens and closes, but it's also planar in the fact that there is some gliding action occurring with that joint as well. Now there are 4 movements we can get with your TMJ. Remember, if we recall from your own study, elevation is to basically close your jaw. Depression is to open it. Retraction pulls things back. So it's kind of harder to do, but if you pull your jaw backwards. And then protraction is forward. So putting your jaw sort of forward like that would be protraction. So those are the 4 major movements we can get here. Now I do get a lot of questions about, hey, what about TMJ? I have TMJ, what does that mean? What's going on here? A lot of people don't actually know what's going on with TMJ, the snapping and clicking and things like that you get with that particular joint disorder. So there's still a lot of questions surrounding cause, what exactly it is. So I really can't give you a very good answer right now. Now the shoulder joint is my forte. I have had 3, maybe 4 shoulder surgeries, 3 I think, on total both shoulders. Because remember, the shoulder joint, although the most movable joint in the body, is quite predispositioned to be injured, because remember that glenoid cavity is very, very shallow, and even with that labrum, you're still at risk for dislocations. Now, because this is a ball and socket joint, remember it's going to do all kinds of things. We have abduction and adduction, we got flexion and extension, you have that medial and lateral rotation. You can also just hold your arm out and turn it in and turn it out. Circumduction, that's basically your arm circles, and then when you go behind your back, that's hyperextension. So there's a ton of different movements we can get with the shoulder. Now remember, to keep the shoulder from popping out in most people, we have that glenoid labrum, the piece of fibrocartilage that's going to surround the glenoid cavity to make sure the head of the humerus does not pop out as we're performing all these different actions. Additionally, we have a group of 4 muscles that we'll learn about when we get to our muscle unit, both in lecture and lab, that are going to help stabilize the joint. Remember, ligaments and the labrum and the muscles are going to help stabilize a joint. So the 4 muscles that we have are supraspinatus, infraspinatus, subscapularis, and teres minor. Their tendons are going to wrap around the shoulder joint and help stabilize it. That's why during any injury recovery, they focus on rotator cuff management and strengthening your rotator cuff to help maintain the stability of the joint. So a couple things I want to talk to you guys about are instability, right? I mentioned earlier that I have what's called multi-directional instability. Oops, there we go. So multi-directional, that means my shoulder, it subluxes, which if you recall from the first video, that means it kind of pops out a little bit, but then it pops right back in. Mine can go anterior, inferior, posterior. It just can kind of go wherever it wants. Typically what's happening is when you have an unstable shoulder joint, it can occur because of genetics. You just naturally have loose ligaments like I do myself, or it can occur from an injury. So if you dislocate your shoulder, you're now more prone to further dislocations and subluxations. Because if you recall from our discussion on histology, the joint capsule is made of dense, irregular connective tissue. It doesn't have a lot of recoil to it. It can stretch, but it doesn't really recoil very well. So when you dislocate a shoulder, the joint capsule is now stretched. It's looser. So you're going to be more prone to dislocations. So what happens is these shoulder structures become stretched, whether it's the ligaments or the capsule itself, and now it's just not as taut as it used to be. Now what I actually had happen to me was a combination of 2 injuries. I had a torn labrum, and there's lots of different types of torn labrums, and I had an injury to my humerus. So the labral tear that I had was called a Bankart lesion. It's an inferior labral tear. There's another type of tear that exists as well that's called a slap tear. That's the one that goes on the top from anterior to posterior. But mine was inferior. Now remember, the labrum, its job is to keep your humeral head inside the glenoid cavity. If it's torn, that job basically gets null and void. So what happened is every time my shoulder popped out and popped back in, because of that, as you can see here, it would hit, the humeral head would hit the glenoid cavity, the bone-on-bone action. And every time it did that, it would take a notch out of my humerus. So this is a normal humeral head right here, and you can see this one here has an indentation in it. That is the second part of my diagnosis, which is called a Hill-Sachs deformity. So a Hill-Sachs deformity is where you have damage to the humeral head due to this constant subluxation that occurs. So treatment was surgery. You go in, you fix the labrum, and then go through a series of months of physical therapy. Now another surgery I had, but on the other shoulder, is called a subacromial decompression. So sometimes subacromial decompression. So subacromial, below the acromion. Okay, so here is, oops, let me get my pointer back. Here is my acromion. Okay, that part of the scapula here. This is my rotator cuff. Sometimes, due to injury or just irritation, you can get bone spurs on the underside of the acromion. And that's going to reduce the space you have between the rotator cuff and the acromion. And that can lead to what's called impingement syndrome. So I'll write that guy down here. So impingement basically means it's harder for you to like move your shoulder. It feels like something's getting pinched in there. Very, very inflamed, very uncomfortable, hard to sleep on. Sometimes it can be reduced with cortisol injections and things like that. Mine was not going away. So what they did is they went in and they shaved away this spur. And you'll notice going from this to that there's much more space. So now I'm able to move my shoulder a lot more. This actually hurt worse than both of my other shoulder surgeries because of the involvement of the bone. Remember, bone is bloody and it's full of nerves, so it can be very, very painful. All right, away from the shoulder, we're going to move down our arm to the elbow. This is a joint that I really don't have too much personal injury with, thankfully. Like a lot of athletes, or former athletes, I have had tendonitis and things like that. But I haven't had anything super severe here. Now the elbow is where your humerus meets the ulna and radius. So this is that joint here. It's a hinge joint, remember, because it basically just does flexion and extension. There's not really side to side movement that we have here because we have all of these major ligaments on the medial and lateral aspects of your elbow joint. Now the one ligament I do want to bring to your attention is the ulnar collateral ligament down here. The UCL is this big ligament that's on the medial surface here of your elbow, and it's important in a surgery that we call Tommy John surgery. So a lot of pitchers in the major leagues, right, they pitch it over 100 miles an hour. When you're throwing, let's see if I can do this very well in a chair. When you're throwing a baseball, you typically are, pulling your arm back, and you it's kind of hard to show you, but you kind of bend the elbow a little bit laterally when you're throwing a baseball. And you can imagine the amount of force you're putting on that medial aspect when you're throwing at 100 plus miles an hour. So that can lead to a tear in the elbow, which is a very, one of the more common injuries you hear about with pitchers when they have to be taken out of the game. So to repair that, we go through what's called Tommy John surgery. They're going to repair that torn ulnar collateral ligament, and it can be done with a tendon from the forearm, from a very long, sort of more tendinous muscle that we'll talk about more later when we get to our muscles. Or you can do a donor graft. So we can use tendon from the forearm. Your hamstrings are also used a lot when we do autografts. Not autografts, but autografts, because they have a large tendon that we can use. So we can see here, your hand would be towards the right, shoulder to the left. Here is that big graft here in the medial compartment. So they've sewn it together, and then in a few months' time, after extensive rehabilitation, they'll be able to come back and pitch again. Now the hip joint is a complicated joint, as you would imagine. You guys have already looked at the hip in lab. It's a very complicated bone, and then add that together with another one, and the sacrum, the pelvis is just a very complicated structure. The hip joint itself is, once again, a ball and socket joint. So it's one, when you actually think about it, we have a ball and a socket. So it sits really well together. Just like the movements of the shoulder, we get the same movements of the hip. We have a labrum. Once again, that acetabular labrum that's going to go in the acetabellum or acetabulum, however you'd like to say it. And it's going to help just deepen that socket, because the last thing we want, as you can see down here, is a dislocation of the pelvis. Now, one thing about pelvic dislocations is that they're incredibly rare in comparison to a shoulder dislocation, because the amount of force that you need to dislodge that femoral head from that really deep socket is quite immense. So you typically see it in things like car accidents. So that's why femur dislocations are quite rare. Usually, when you have a hip dislocation, it's going to go posterior, not anterior. And so with a posterior hip dislocation, what you'll see is the leg is going to be internally rotated, and it'll be adducted, so it'll be inside. And so if you have an anterior, it would be the opposite. Okay, and that's different from what you would see with like a femoral fracture, which can also occur if the force is strong enough when you have a hip dislocation. With a femoral fracture, what you'll see, it's kind of hard for me because I don't have legs to show you right now, but typically with a femoral dislocation, you'll have one leg that's a little bit shorter than the other, is what you will see on presentation, on top of a huge amount of pain for the patient. Now, another reason our hip joint is so strong is because of the large ligaments that we have just connecting that femur to the pelvis. There's quite a few, and the one that I really want to focus on today is the iliofemoral ligament. It's this big Y-shaped ligament that's found in the anterior portion of the hip, and it's the strongest ligament in the body. What it does is it helps with hyperextension, but really it's dealing with maintaining posture. So when you stand up, your pelvis actually tilts a little bit posterior, and what happens is that ligament is really tight in that position. And what it does is, by having a really tight ligament in the standing position, it keeps your torso from going backwards, and it reduces the need for extra muscle contraction. So it takes the load off of the muscles that otherwise would need to be contracting quite hard or longer to maintain that standing posture. And then as you sit down, the ligament will relax. Now, some of you may be asking, well, what about splits? People that do the front splits, that's definitely hyperextension. Those that perform the splits, they typically have more flexibility in that particular ligament. And a lot of times, if you look at that posterior leg too, you'll notice that it's externally rotated, because it actually helps stretch the ligament a little bit more. So when you externally rotate, it helps stretch the ligament, increasing the flexibility. Once again, flexibility of ligaments and muscles is something that you can just be born with, right? There are people that are extremely limber due to their genetics, and there are others who have just been training their whole lives, so their bodies have just naturally learned how to be a bit more lax. All right, on to the knee joint, and we only have one more joint left. The knee is probably the most complex joint. There are menisci and ligaments and fat pads and multiple bones that all kind of come together in one area. It, like the elbow, is a hinge joint. So we're going to get flexion of the leg. Remember, leg means below the knee, not the whole leg. So we get flexion of the leg, we get extension of the leg, and we can also get some slight medial and lateral rotation. Not a lot, but we can get just a little bit. So that's why it's considered a modified hinge. Now, when we look at the ligaments here, okay, so let's look at our view first. We have removed the patella, and the knee is bent because I can see the surface of the condyles here. So we have 4 ligaments. We have an ACL, which is your anterior cruciate ligament. We have the PCL, which is the posterior cruciate ligament, cruciate, cross. We have our lateral collateral ligament, or your fibular collateral ligament. And we have the medial collateral ligament, the MCL, okay? Now, the ACL and PCL, right, they're the internal ligaments that we have. And what the ACL does is it prevents the tibia from sliding forward on the femur. This is actually the main ligament that's injured most of the time in knee injuries, is that ACL. The PCL is going to prevent posterior sliding, so keeping that tibia from going backwards as we, say, walk down the stairs, okay? Now, the MCL, the medial collateral ligament here, this is another one that's also often injured. And what's very interesting about the medial versus the lateral collateral is if you look closely, you'll notice the LCL is not connected to the lateral meniscus in any way. The MCL is. So the LCL is going to help keep stability on the lateral surface of the knee. The MCL is keeping the medial aspect strong. Injuries to the MCL are often due to forces coming from the lateral aspect of the knee. So getting tackled at the knee, whether it was a slide tackle in soccer or maybe you got tackled in rugby or in football. When that happens, it puts a lot of force on this medial aspect of the knee and it can tear the MCL. But because the MCL is also attached to the medial meniscus, it can also lead to a tear in the meniscus. And sometimes, if you're super unlucky, you can also get an ACL tear. It's called the trifecta. So you tear 2 ligaments and you tear your medial meniscus. Very, very fun rehab. Sorry about that, got a little excited. So one other thing that can happen with a knee are patellar dislocations. So as you can see, those of you that are squeamish, you can just kind of cover that with your hand. This woman, she's actually able to do this on her own. I had this happen to me when I played rugby in college. So the patella is basically slipping out of the patellar groove. And for me, when it happened, obviously it's incredibly painful. They straighten your knee and bend it again, or bend it and straighten it, whatever order. I was not watching. And it pops right back into place. I also had I think a lateral meniscal tear as well. So I'm missing part of my meniscus because I had a meniscectomy, which hopefully you guys were able to watch, or a partial meniscectomy. So hopefully you guys watched that video from the last lecture video I did. So this is a kneecap dislocation, not a knee dislocation. If you dislocate your knee, that means the femur and the tibia have separated. This is a patellar dislocation, so it's popped out of joint there. Now the last thing we want to talk about today is the ankle. Okay, so the ankle, as you can see, and as we've seen in lab, is made of a connection point between the tibia, the fibula, and that talus. And then the foot itself just has a ton of different ligaments that are holding those bones and the other smaller bones together when you are walking. So this is a hinge joint as well. It does dorsiflexion and plantar flexion. Remember, when we're talking about flexion and extension in the foot, we don't say flexion and extension. We say, so this is my sole of my foot, top of my foot. If you bend up, that's dorsiflexion. If you point your toe, that's going to be plantar flexion. Now, in this class, by no means are we learning every single ligament here. That's ridiculous. What we are going to learn is that there are two major ligaments. We have the medial ligament, which is the deltoid ligament, composed of 4 ligaments. And then over here, if we look at the lateral view, we have the lateral ligament. So the deltoid ligament strengthens the medial aspect of the ankle joint, and then you have the lateral ligament, which obviously strengthens the lateral aspect. So what injuries typically happen here at the ankle joint? Ankle sprains. So there's different types of ankle sprains. We can have a common ankle sprain, which is typically going to affect the anterior talofibular ligament. You don't need to know that. But it's typically this guy here is the one that's going to be affected. Usually for those of you that have them, you know it's because you were walking or running and you rolled your ankle. You inverted it and tore the ligament. Once again, I have super lax ligaments, so I have on many occasions been on a jog, rolled my ankle, and just kept going because my ligaments are stretchier, so they don't tear as easy as other individuals. A high ankle sprain, for those of you that have had a high ankle sprain, that's going to involve the syndesmosis between the tibia and the fibula. So remember the syndesmosis, we had that anterior tibiofibular ligament, which connected them sort of in this anterior region here. And then we also had that interosseous membrane that was between both bones. So tears there, that's a high ankle sprain. And it's usually caused by sudden twisting or cutting like you do when you're running in football or basketball or soccer. So you kind of stop and twist move can actually lead to a higher ankle sprain. That's all I have for you guys today. Once again, if you have any questions, you can always email me. Feel free to review that material on the types of synovial joints and the actions. Again, if you need to, rewatch this video or the first video as needed as well. And you guys are good to go for your very first test. I'll see you later.